Okay, good morning, and welcome to the participants as well as the presenters. Can I request all the presenters to please turn on your videos? Let's have a look at you, and all the participants can also see you as I quickly introduce you. So welcome to session 4, Overcoming Demand Barriers. I think there are 4 parallel sessions happening, so we waited. I hope more people will join in as we are progressing. So we have 3 presentations lined up in this particular session. And we have 3 presenters. The first presenter will be Bhargav Sriprakash, and he's the founder and CEO of Friends Learn, a life science and health technology startup based in San Francisco, has offices also in Chennai. And I was reading his CV, and the most interesting thing is that he's an entrepreneur, and despite being an engineer and a designer, he's an entrepreneur. And I think the most important thing is he has 4 patents to his credit in the field of AI and technology. And he currently serves as the research, translation, and innovation partner at the Carnegie Mellon University, and was also on the scientific committee of this University of Stanford School of Medicine. So he's going to be our first speaker. Our second speaker is going to be Dr. Bhavani Shankar Tripathi, and he's a SBCC specialist, and he has over 20 years of experience working in the area of public health and environmental communication. He has been working in the India country office, and he has been supporting child health and routine immunization programs. He was one of the key members who started the Gavi communication system in over 12 states of the country. And currently he is positioned in New York as Communication for Development UNICEF office. Our third speaker is Dr. Noor. She's a medical doctor, and Dr. Noor is a global expert and conducts research in maternal and child health. Currently, she is the director of Precision Health Consultants, PHC, that global, and she's based out of Pakistan as well as the US. She has served as faculty in the Zulfikar Ali Bhutto Institute of Science and Technology in Pakistan, and has been also a faculty at the Johns Hopkins Center of Public Health in the USA. We welcome all our 3 speakers. They are part of larger teams. I'm sure they will introduce their teams as they make their presentations. Just a few ground rules before we begin. All the participants know this, that their videos and mics have been turned off. We request you to start posting your questions in the chat box, and we can really extend the question and answers more. And as the speakers finish their presentations, each speaker will be speaking for about 10 minutes, and we will take all questions after all the 3 presentations are over. I request all the speakers to remain on time so that we can have a good discussion at the end. So let's begin, and I request now Bhargav to please start his presentation. Thank you.
Hi everyone, my name is Bhargav Sriprakash, and I'm here to tell you about our project, which is a randomized controlled trial of a mobile app that we've designed for type 1 and type 2 diabetic children. This study is a multi-institutional collaboration between physicians and data scientists and myself and my team at Friends Learn, which is really developing the technology. Dr. Usha Sriram is an endocrinologist and a clinician, the head of the diabetes clinic at VHS Hospital in Chennai in India. Professor Rema Padman, who heads the digital vaccine project at Carnegie Mellon University, is a data scientist, and she's also assisted by Professor Yi-Chin Lin from Hofstra University, and myself on behalf of Friends Learn, which is the company that is developing this technology. The purpose of this study was really to assess and validate a new module based on technology that we've developed and and been researching at the Center for or the Digital Vaccine Project at Carnegie Mellon. So we really built upon our understanding of how to use gaming and virtual reality technology powered with AI to be able to nudge positive diet and lifestyle related behavior in children. And that app, Fuya, has been studied through numerous randomized controlled trials in the past. And in fact, even with researchers from the Bloomberg School of Public Health at CCP, we've recently published in JMIR, in their M Health and U Health edition, the results of a randomized controlled trial. So we're extending the evidence base in this population of diabetic patients, really to look at the longitudinal impacts of a new module to help diabetic children better manage their condition. The overall objectives is to actually assess through a three-arm randomized controlled trial and look at outcomes at the biomarker level as a result of our attempt to induce healthier diet and lifestyle habits. So we're looking at HbA1c, glycemic excursions, the BMI of children over a period of time. And we're also looking to understand a dose response. So every time a child gets an exposure, to really understand the decay and how that affects these parameters over a period of time. And additionally, we're interested in learning outcomes, really to see how the neurocognitive training mechanisms are leading to habit formation, both through Fuya, which is administered to one out of the three arms of the RCT design, as well as Fuya D, which is the new module really purpose-built to help children better manage their diabetes condition. So this randomized controlled trial is going to be administered to children that present to the clinic at BHS Hospital. These patients are either type 1 or type 2 diabetes patients, and are, after informed consent and assent, are included based on whether their parents are willing to help in filling out these forms and questionnaires. And one of the inclusion criteria is that these children have access to a smartphone or an iOS device or an Android tablet. And the exclusion criteria is that if children have any specialized diets or any other conditions that may restrict their ability to benefit from the built-in coaching mechanisms and the behavior reinforcement mechanisms that have been gamified, then they would be excluded from being eligible to participate. But the target is really to look at around 382 patients and study them over a period of time. So Fuya itself is a mobile app that we've developed and has been studied through multiple randomized controlled trials, but it's an animated video game, the whole theme being that it's the world's epic food fight. And we developed it at Friends Learn, and it's really based on neuroscience and neuroplasticity and neurocognitive training, which we're able to induce using immersive technology, virtual reality technology delivered on a mobile device, and really powered on the back end in terms of what content gets shown and how it gets shown, and the patterns with which this virtual reality experience is dynamically configured is powered by a neural network. And the whole point of Fuya is to gently kind of remind and coach and then nudge children into a healthier neurobehavior state. And this we achieve as a result of this repeated exposure to this gamified VR experience. And the whole purpose is to reduce the risk of lifestyle diseases and by helping children make healthier food and lifestyle choices. Quickly wanted to show you a few screenshots of Fuya, since Fuya has been around and actually available on the App Store as well as the Google Play Store worldwide. But it's really a narrative-driven, gamified, immersive experience. The child themselves goes on a quest to protect their world, which they also explore, and they protect it from enemies of health that come in various shapes and forms, and children are actually learning as they progress through levels, gradually adapting to the pace of not just the user interface and the experience, but also to the progression of the information. And children are then immersed in these 3D worlds where they encounter food, and food choices affect their superpowers, and they really get to experience implicitly understand or develop an understanding of how their choices impact their health. Fuya D, on the other hand, is really catering to a population of children that have either type 1 or type 2 diabetes. The focus beyond the experience of Fuya is really to help them understand how they can count carbs and use energy balance and insulin to better manage their condition. So another important aspect of Fuya D is helping these children learn how to dose insulin so that they can maintain balance and stay in the safe zone as far as their glucose levels are concerned. So the objective of Fuya D is to really harness the capabilities of Fuya, but with a little bit of a twist in that it goes much deeper into the subject matter of helping a child, care for themselves, and they do this with similar mechanisms of having their character and their condition, observing them, experiencing the symptoms, all through gamified VR, narrative-driven, story-driven, and are able to kind of have a deeply internalized understanding of various decisions that they would make. Another really important aspect of Fuya D would be that children get to understand macro and micronutrients in various foods that they encounter, and especially in the context of carbohydrates and how that may be affecting their blood sugar levels. So not all carbs are the same, and children with diabetes have to be much more aware of that, and should know when to use or when to consume a food that has a high glycemic index versus a low glycemic index, and to be mindful of all the possible symptoms that may be an indication for them to be able to take some action. So here we are able to, subtly and contextually reinforce the carbohydrate levels, the glycemic index, as well as the concept of glycemic load. So as they, for example, power up on bananas or some other item in this context of Fuya D, they understand that it's not just about the glycemic index, but also the number of servings, and therefore what kind of load it may have on the avatar's blood sugar level. So as part of this RCT, there are several instruments and several biomarkers of interest that we're tracking and collecting over this longitudinal period. Children as part of this trial are administered the intervention, are part of the trial for at least 6 months. And so at baseline, the child actually, with the help of the parent, uh, answers a bunch of surveys to give us information about their background, their habits. And then on a monthly basis, patients or also patients and parents are required to answer a survey or questionnaire. And then as part of their standard of care, these children are required to come into the clinic, take their insulin, and also for them to undergo clinical checks, or have a physician basically take their height, weight, and do their blood work. So that becomes a critical set of data that we add to the patient data set as part of our analysis. And the other really valuable uh, outcome that we're interested in, to be able to thread the online experience with these clinical outcomes, is game telemetry data, which is essentially a stream of a very high resolution um, uh, set of data that we generate through analytics of how the child is actually engaging with both FUYA and FUYA-D. So we're able to reconstruct almost after the game session at a very high resolution to look at the time lapsed between different events of interest, as well as different pathways that a child chooses, because this is a free form mode of interactive engagement and communication, I guess. So behavior change communication. So there are different pathways that a child can take. And so we're able to isolate, the patterns associated with how the neurocognitive training mechanisms were invoked, as well as, how that links to the clinical outcomes. And then we are also looking at food logs maintained by the children, and then actual food choices that children make when they come to the clinic, and have an option to kind of make choices from a buffet of snacks and food. So this ongoing trial is looking to, it's IRB approved here in India and at Carnegie Mellon, and we're beginning to recruit patients, and we're really excited to see and to extend the science of digital vaccines, and the idea that and digital therapeutics, to really be able to see how we can map biomarker outcomes to social behavior change communications and gamified virtual reality content. So would love to take your feedback and questions, and it would help us as we navigate the experimental phase and the data collection phase of our project. So thank you again, and look forward to hearing your questions and taking your feedback. Thanks.
Thank you so much. Nice presentation. We've understood the project. Very interesting. So anybody who has any questions, request you to start, please, posting them on the chat box. We now go on to our second presentation. Can I request Dr. Bhavani Shankar Tripathi to please begin and turn on your video? Sir, we request you to then now begin your presentation. Thank you.
Sure. Thank you, Archana. And good morning, everybody. Let me start sharing my screen and then I hope everybody can see it.
Yes, it is visible, Bhavani. Thank you.
Yeah. But before this, I'll stop share for a second and let me just tell you that I have been introduced. My name is Dr. Bhavani Shankar Tripathi by Archana. I just wanted to correct something. I'm not based in New York. I'm based in India and work as a global consultant with the UNICEF New York office for communications for development. But I'll switch off this for a second and introduce my other team members for this presentation, who are Professor Nisar Ahmed from Envision's Development Institute of Development, Delhi, co-partner Varsha Chanda, who is the Chief Executive Officer for Envision Institute of Development, and Rania Elisawi, who is the C4D specialist and based at the UNICEF New York headquarters. Let me give you a brief about their bios. For a second, I'll take 2 extra seconds because they are very important members of this initiative called Boosting Routine Immunization Demand Generation. The acronym is BRIDGE, become very popular, and how interpersonal communication skills of frontline workers were used to change behaviors within the community to increase demand for immunization. So for a second, I'm going to stop sharing this and then come back again. And let me introduce my co-partners here. Nisar Ahmed, Professor Nisar Ahmed, I would rather say, is an alumnus of the University of Delhi and Maastricht School of Management, Netherlands. He is a change management coach, certified by Innovations Associates, Boston, USA. He possesses about 40 years experience in the corporate sector, development sector, and academics jointly. Currently, he holds the position of Executive Director of Envision's Institute of Development, EID. It's an organization that's with special
Bhavani,
consultative status. Yeah.
Yeah. Bhavani, I think let's do away with this because they're there. And we just go
for interest of time, then I'll okay. We can share it later on with people then. Yeah. Okay. Let me then share the screen again. Go back to. All right. Okay. Now we all know that familiarity breeds contempt, but then we also should understand that familiarity also improves trust, and it can remove hesitancy because you come close to people and you are able to interact with them. So how does familiarity work in creating demand for immunization or immunization, where a parent is supposed to take the child for immunization 7 times in 5 years, and how familiarity can familiarize community and thus build the community trust in health services beyond immunization. Of course, in the long term, this whole interactions of familiarity would improve key health indicators, because immunization is considered as a gateway to other behaviors, public health behaviors. So we'll look at the problem analysis and based on survey data carried out by WHO. Now, presuming that information availability is sufficient, I mean, that's what exactly is thought, that if we inform people and make them aware about certain things, that should be sufficient to actually change the behaviors and create demand for, in this case, create demand for immunization. And we realize that according to the Family Health Survey, the full immunization coverage is around 62%. So the number of children who are born in this country is 2.5 crore children every year are born in this country, 2.5 crores, close to 25 million children. But when you say 62% get immunized, which means that close to 9 million children remain unvaccinated or partially vaccinated and thus, and the problem is that we see two very significant barriers that have been identified from the data that is presented here. And the two barriers is, one of them is the awareness and information gap, and the second is the apprehensions resulting from the adverse events following immunization. Together, almost equally, together they actually form 63% of the barriers that lead to inadequate, lead to, of course, low demand for and low vaccine confidence. Now, communication happens to be inadequate. That is what has been found. And it's not persuasive enough. The kind of messaging that people are hearing, the parents are hearing, or their concerns are probably not getting answered. So it's not persuasive enough to get people to actually bring their children for immunization. In this entire demand generation and the whole concept of familiarity, the central character or the main actor is our community health worker, or known as the frontline worker. So low vaccine confidence actually continues to be a behavioral challenge in getting the parents to bring their children for immunization. As I said earlier, 7 times as per the national schedule within the 5-year period. There is enough evidence, not only in India, but across, which shows that dialogue communication, getting into a dialogue with other people or with the concerned audiences, stakeholders, that enables immunization decision making, and it builds supportive environment for behavior change from low vaccine confidence to the desired behavior of the parent bringing the child to the immunization center on the scheduled date at the scheduled time for the scheduled vaccination. So that's the kind of behavior change that needs to happen, and dialogic communication supports that. Now, community health workers, CSWs, or FLWs, we'll use that interchangeably here, are once they are skilled in initiating and closing this dialogue. I mean, you had to initiate a dialogue, start this dialogue, and they closed it on the benefits of childhood vaccination. That we have seen effectively bridges the gap in this behavior of low confidence and bringing the child to the immunization center. So if you look at the potential that close to about 2.4 million community workers have, we have the total number of community health workers comprising of 3 different categories of workers is about 224 lakh, which is, it's a strong community of health workers, and that's about 860,000 accredited social health activity, which is the ASHAs. We have close to about 13 lakh Anganwadi workers, and then the remaining 1,98,000, or close to 2 lakh ANMs, auxiliary nurse and midwives. They serve together jointly. They serve the first point of contact for communities. Ashas is directly at the village level, at the household level, she's able to contact, and then communities contact the ANMs and the Anganwadi workers together. So if you look at the potential of these 2.4 million community health workers, this has been recognized as a strong foundation that supports SBCC practices at the community level in connection with BCC. So for outcome-oriented social and behavior change, it was important to shift this limited understanding of interpersonal communication from doing just face-to-face to delivering the information with a parent to practicing almost a much larger process of engagement with the whole community as a cohesive unit that influences health-seeking behaviors. The bridge intervention actually, yeah, the bridge intervention sought to build the skills of this important community health worker to create a systemic structure for engaging at several levels to create an enabling environment for change. I would like to mention here one very important thing before I go to the let me talk here about the fact that behavior change is, this particular behavior change fact is based on the theory of Bandura's self-efficacy, which actually talks about, that an individual's capacity or capability, that is own skills, his or her actions are influenced by observing other people's actions. Hence the shift, as we say, from face-to-face communication to a whole community. Now recall the social ecological model theory, where the center is the individual at the community level, and all other influencing factors and community members who are around it. From a trainer's point of view, self-efficacy is also structured through a combination of proactive and providing the enabling environment. So a trainer is able to provide that environment to the trainee and putting the learned skills, the adopted skills to use. Therefore, in Bridge, a two-step efficacy measurement process was introduced. One efficacy which is gained at within the classroom through a simulated circumstance, and then that same efficacy is then put into practice at the field level. So looking at how the toolkit, Bridge toolkit, was designed, the boosting routine immunization demand generation was introduced nationwide to skill these AAAs, as we say, the community health workers or the frontline workers, with field-tested methods and processes. The need was a compact package that could be delivered in a short time frame. In fact, it's as short as a 4-hour module. Considering how frontline workers are constantly occupied, not only in their day-to-day work, but also in attending other training programs. That was a challenge, how to bring all these skills enhancement within this short period. So both for the trainers and the frontline workers outside the classrooms, tools were introduced for self-assessment. There was competency testing, there was quality assessments, and then finally out in the field, there was supportive supervision. A whole lot of tools. Interactive tools like Who Wants to Save a Million as a game was very popular during the training, and as part of the methodology that we use. So what was the intervention all about? At the national level, it was developed initially in English, and then over a whole lot of 14 different languages, it was converted and translated into different languages. State level trainers were selected for delivering these trainings in the local dialects. An operational guideline was created to help organize and roll out Bridge in the trainings. Then you have the quality control. As I mentioned in the previous slide, competency control was very important. A self-assessment tool enabled their traders to grade their own quality as Bridge trainers and to improve identified gaps. In fact, I must say that this was quite a pioneering thing to happen in any training in India. What about the frontline worker training? The inputs and tools that were used was an easy to use IPC guide, because post training, when they actually go out and start practicing their skills, the IPC guide would be very useful. And so the actions that they have learned in the classroom was then made available to them as a reference guide in the field. The fourth was the monitoring, because once the training happens, once the practice of behavior change initiatives, community engagement processes, interpersonal communication starts happening outside, they are then monitored, and a quality assurance tool was designed as to how do we assess the quality of the training completion. The data was then collected. The real-time data was collected through an SMS-based monitoring application for almost more than, I think, 26,000 training sessions that were held. And then finally supportive supervision, because right out in the field when they are practicing, are they being supervised and are they being provided the necessary support? Because that hand-holding is so important to correct their knowledge in case there are gaps. And that methodology was very, very successful.
And can I request you to conclude in the next 2 minutes, please?
2 minutes, yes. So if you look at the results that we have, you see the chart here, very simple to understand. We have the grading of the trainers through the self-assessment, which was, I said, as pioneering in health. The grading actually ensured the trainers' preparedness for field training. And on the other hand, it also shows the output results. So you see that there is a corresponding increase in the increase in knowledge and uptake of knowledge with the proportion of highly proficient trainers from 30% to 93% and from 11% to 32%. That was quite a very encouraging result that we have. So training communication related to routine immunization operation, remember, it actually recommended we include government officials dealing with health communication and routine immunization possibly. That was very specifically mentioned within our operational guideline. What we actually found is that about 66% of, you can see the pie chart, majority. So there is the 33%, close to 30% who were from the medical background, and there was another 33% who were from the communications background. So about 2/3 of the trainers were from these recommended categories, whereas the rest of them were either supervisors from the paramedical administration training. And so this was a challenge in many states where they found it difficult to provide the specified kind of trainers. So the results B actually shows here that when we conducted an online assessment, there was a quiz which was introduced after 6 months of practice. The learning was assessed, and the focus areas, the gaps were identified so that we could do a refresher training of these. In fact, we had very good feedback which came in. 78% they provided correct answers, 95% frontline workers acknowledged IPC's importance. 80 to 90% of the responses gave correct answers to the questions on Gather. Gather is a tool, IPC tool developed by UNICEF. The quiz also shows results on areas of concern, and then refresher trainings were recommended for understood skills, of the participants. And the scores corroborated with the findings during field observations very clearly. So those tools are available. Here I have got what I say is many of the, kind of directly from what the participants found. They have been able to develop better relations with people, they have convinced pregnant women to come to the PHCs for ANC. So as I said, immunization only serves as a gateway behavior because it also leads to increased ANC checkups and so on and so forth. The mock sessions were very important. So these, how to hold community meetings more effectively.
Bhavani, can I request you to conclude, please?
Yeah, the last slide. I'm almost on the last slide.
Yeah.
And these other aspects were there. The learnings, everyday advocacy with state governments has created ownership for the program. It's been based on field references, successful to prevent dissociation of knowledge. It's frequent and different trainings.
Just need to give us the conclusion. Just conclude.
Yeah, it's concluded. So what has been proved that interpersonal communication has gone beyond the simple, face-to-face communication to a very precise and methodical and field-tested methods of enhancing quality of training. This has now been converted into many different languages for national and international use. We are now converting an e-module. There is a dashboard available, and a community of practitioners for Bridge has been developed. Any further queries? We are available. You can also write to Nisar Ahmed and Varsha Chanda directly. for this, I can answer questions here if required.
Thank you. Thank you so much.
Thank you. Thank you for
So our third speaker is Dr. Noor, and we've overstepped our little time, but you will get your full time. Please, can I request you to now start your presentation?
Yeah, Archana, I think, yeah.
Hello to
the-
everyone.
Yeah, yours is a
Thank you
recording.
for
Yeah,
this
they
I
play.
sent
Asia
video.
SBCC
Thank you.
conversation, for providing this opportunity to share with you the vaccine indicator and reminder band formative evaluation study. I'm Nurisaba Rashani, the innovator of the VIR band and principal investigator of the VIR band formative evaluation conducted in Karachi, Pakistan and KB State, Nigeria. Today, I will be focusing on our Karachi study only, as my colleagues will be presenting the Nigeria study at another platform. For this formative evaluation, we use the Donovan quality framework to identify the structures and processes that needed to be in place for implementing the VIR band intervention, for our goal to address the gap in childhood routine immunization, timeliness, and completion. We also wanted to address the challenges and facilitators at the supply side, that is the healthcare system level, and the demand side, which is uptake by the communities of the VIR band intervention. The formative evaluation also looked at the policy arena to ensure sustainability of the intervention. The gap in routine immunization, timeliness, and completion is a challenge for many developing countries. In Pakistan, 8% of the children who receive their first dose of BCG vaccine at birth never complete their third dose of pentavalent vaccine. To address this gap, the VIR band was conceived in a dream. It became a concept and in November of 2012 was awarded the Gates Foundation Grand Challenges Exploration Innovations in Health. The VIR band is a mechanical device. It consists of a time indicator strip encased in a silicone band. The time indicator strip has a blister containing vegetable dye. When the blister is pressed, it releases the dye, which diffuses by capillary action in a time-controlled manner over a patented membrane. The dye fully colors the white membrane according to a preset time interval of either 6 weeks or 4 weeks. This visual cue acts as an active reminder to the parents when it is time to return to the vaccination center for the subsequent doses of vaccine. The VIR band proof of concept study, funded by the Gates Foundation, was completed in 2015, and the learnings from it were used to refine the second generation VIR band and the formative evaluation study. The VIR band consists of 3 color-coded bands. The yellow band is given at the time of first vaccination visit, acting as a reminder for the second visit. The second purple band is given at the time of the second visit and as a reminder for the third. And the third green band is given at the time of the third visit as a reminder for the fourth visit. The VIR band formative evaluation study in Karachi, Pakistan and KB State, Nigeria were funded by the International Initiative for Impact Evaluation. The study's implementing partners were TBI in Pakistan and HSDF in Nigeria. My role as the PI and director at Precision was to provide the technical details for the design of the band, scientific methods for the 3 studies, and continued advocacy for vaccines. You can see on page 4 how the VIR band intervention is set up. When a child visits the vaccination center, parents are consented to enroll their child to receive the VIR band. Once the parents agree and the child receives the first dose of vaccines, the yellow band is activated and placed on the ankle of the infant. The parents are explained that when the red dye fills the entire white membrane, they have to bring the child back in 6 weeks to receive the first dose of the pentavalent vaccine. And on the second visit, when the parents consent, the child is vaccinated, the staff activates the VIR band and firmly secures it on the baby's ankle and advises the parents similarly. When the parents return for the third time, the child is provided the green band, which acts as a reminder for the third dose of the pentavalent vaccine. The child's social demographic information and vaccination record is entered into a digital online vaccine registry during each visit. Once the child receives the third dose of pentavalent vaccine, the parents are provided a laminated card which has the vaccine record as well as the VMR number. The parents are also advised to bring the child at 9 months and 15 months for the measles vaccine. I will not go over all the results of our study. And on page 5, I would like to share with you the key findings of the VIR band acceptance and compliance. Our team approached every parent coming to the vaccination center for the first dose of vaccine for their child. According to the selection criteria, 497 infants were enrolled to receive the yellow VIR band. Each child's record was updated on subsequent visits and enrolled to receive the follow-up bands. Every child was followed for 18 weeks, and the parents were requested for an exit interview after receiving the third or the green VIR band. Our most encouraging finding was a high VIR band acceptance rate. Almost all parents whose children met the eligibility criteria agreed to enroll in the study. Not only this, more than 90% of the parents came back to the vaccination center with the VIR band, and 98% of the parents in one study site said they would recommend the VIR band to their family and friends. I don't have the numbers here, but we had a similar VIR band acceptance and compliance rate in Kebbi State, Nigeria. To identify the structures and processes required for the demand for VIR band, we conducted a detailed social mapping exercise in our 2 study sites. We identified every venue of social interaction and gathering where we could disseminate the message of importance of timely and complete vaccination. We used the 4-level socio-ecological model to reach every stakeholder who could influence the uptake of routine immunization in the community, and developed a comprehensive community engagement and communication plan. On page 7, you will see glimpses of our outreach to the community. We made sure to reach every member of the community. We conducted vaccination information sessions with the following: with 3,800 parents in vaccination centers, 728 students enrolled in public and private schools, 554 community members attending mosques, churches, Hindu temples, the Rotary Club, sports clubs, and roadside cafes. About 147 lady health workers and 26 doctors in the private sectors practicing in the community were also visited and sensitized about the VIR band and the importance of vaccination. We held detailed meetings with 125 religious and political leaders, and 24 male and female youth were trained as child health ambassadors. A total of 8,700 VIR band infographics and BCG days, vaccine days, and locations were handed out individually. We had a robust set of findings. In our formative evaluation, we identified that the healthcare system would need dedicated space and staff for VIR band enrollment and health communication interventions. And this would not require any additional resources. The health managers would just need to prioritize health communication. On page 9, we detail the health workers' training in health information technology and digital entry of immunization records, which needs to be in place, not only to track the VIR band follow-up, but there's also a pressing need to modernize the vaccine registry system and to be done with the paper-based records. We also identified that frontline workers need to be trained in patient flow management. In our final set of findings from the health system's level needs, we see the buy-in from frontline workers, healthcare managers, and policymakers as the key to success. There is no other way for any intervention to succeed. Coming now to our community level structures and processes. We trained youth from the community to promote our message and recognize families who ensure timely and complete vaccination of their children. The key to the success of the VIR intervention was that it became a household name as we worked to bring child health and immunization and made it a discussion at the household level. The one major challenge we faced was malfunctioning of the time strip in the purple and green bands. Despite every measure we took and ensured 99% accurate time strip indicator during our trial phase, we faced the problem of arrested dye progression during the formative evaluation. As soon as this malfunction was detected, we reached out to our manufacturer to find the cause of this malfunction. Despite all their efforts, they could not find the answer. However, once we ensure that we have a 99% accurate time indicator, which is also low cost, there will be no holding back of the VIR bend in intervention and scaling it up. The financial and time cost are some of the other challenges in conducting a full-scale RTI and impact evaluation. But we are optimistic as during our intervention, our results were cross-checked by development partners and they were very supportive. The simplicity of the VIR band is recognized by experts in public health, and this is the key to its success and large-scale rollout. VIR band was conceived out of a dream, and it should be the promise to close the gap of vaccination timeliness and completion for every child. Thank you for your attention.
Thank you, Noor. If you'd like to add anything, just quickly, and then we can ask some questions. If there are any more questions, we can take a few more.
Yeah, thank you very much, Archana. It is wonderful to be amongst a group of like-minded colleagues who are interested in digitalizing vaccination and our approach and communication. So I think what Dr. Tripathi and everybody else were also like, it's a common theme. Like we need to bring modernization. We need not only in the digital technologies, but also what is currently existing, like in terms of vaccine registries and in terms of smoothing out all the setbacks whenever they enter digitally, the vaccine registries, the enrollment, and also the trainings of the health frontline workers and the communications training and their assessments. So I think we are like at the right time now for any implementation that does address the use of modern technology. And these are low cost interventions, and the modern technology is also there. It's just a matter of a political will by the policymakers at both the global level as well as the national and the state levels to uptake of this technology and to introduce it and move forward with it. And I think we need more success stories like this. And once again, thank you very much to everyone for this opportunity.
So can I ask you a question?
Yes.
I was very interested in knowing. So were there not any cultural taboos and challenges that were faced in getting a band put on a baby in?
Yes. So
like
what
to
we
share
did,
those?
yes. So actually, in the first phase, our proof of concept study, we used a human-centered design process to design an vaccine indicator and reminder band, and like we did tons of qualitative interviews where we showed the parents, like healthcare providers, vaccinators, as well as parents, and different formats or flavors of it. We even had a digital component. We had a locket. We had a band that was made out of beads and threads, because we were employing all of our cultural aspects, like what we use for our children. So we showed them different things, and this was our concept that if we have the band on the ankle of the infant, it would be safer, so the infant won't be able to put it in their mouth, so that was our logic of having the ankle band. And like, for instance, like when we asked the fathers and the vaccinators, who do you think should wear the band? Should it be the mother or the child? And then the fathers and the vaccinators, they said, oh no, the mother should wear it because she's the one who's constantly looking at it and she would be reminded. And when we asked the mothers were like, no, the child should wear it because we cook, we like wash clothes with our hands are immersed in water, we cook over open fires. So of course, like we went ahead with the smart ones. We listen to what the mothers had to say. And yeah, I mean, like even simple things like the color of the band, like we wanted to make sure it was culturally appropriate.
Yes.
So initially our first band was actually green in color. But when we introduced that green color, some of the people, like, because in Pakistan, we have like a very large Muslim majority country, and there are some groups where they felt that the green color is too sacred to be put on the ankle of an infant. So we said, okay, then we need to have a culturally and religiously neutral color. So we decided not to go with like orange or green or even black. Yeah, so a lot of thought process and a lot of effort and a lot of input went into the design of the PIR band.
Okay. I have another question for Bhargava. Again, what is the possibility of using this app in various kinds of socio-cultural contexts, and how were the food directives and food advices being given culturally rooted while the app was being developed? And is it only for a specific cultural context, or can it be used in different cultures also? Is Bhargav there, or? I think I don't see him. Okay, but that's going to be an important concern. Also, can I ask Dr. Tripathi and Varsha if you would like to also come in and elaborate on some of the challenges that you feel that are there in implementing the Bridge program?
Varsha, go ahead.
Yeah, hi.
Varsha, go ahead. Yeah.
Thank you, Bhavan. So Bridge has multiple challenges, but the major one that we faced was that many of the frontline workers had very short time. States may not have been ready with giving the budgets, or budgets may not be available if they have not put in their PIPs in their annual planning. Getting good trainers for the frontline was also very important. Getting all the materials together for the training in terms of even the IPC skill guide, which had to be translated to the numerous languages that we have in India, was another one.
Yeah.
Lisa, would you like to add some more challenges to this?
Yeah, I think I've been, yeah, just quickly, because we need to wind up the session. I'm getting instructions that the other sessions are beginning and we need to wind up quickly.
Just one last, I will add that many a times a state trainer who had undergone the training of trainers, sometimes they were also not available because they were the regular workforce doing some other responsibility. So even their availability was an issue at times. Thank you.
Yeah. Okay, thank you. I think 3 very interesting presentations looking at 3 very different models and approaches to creating demand. I think they've been very, very insightful and I think lovely presentations. All the presenters can be contacted. I think their emails are there and the organizers can also post them for you. Thank you so much for joining us for this session, and to the presenters, excellent presentations. And we look forward to remaining in touch with you and taking this, learning more about your projects. Thank you to all the participants for joining in. There are 3 other sessions now beginning. They have been posted on the chat box, their links. Please do join in and for these sessions too. Thank you so much.
Thank you very much, Archana, for moderating.
Thank you.
Thanks.